after all that flattery for Chris, I'd like to invite you up. And Jerry and Armelle, come on up, take a seat. And yeah, Nupur as well. And yes, please bring that.
Oh.
Here you go. Here you go. I'm going to give this to you.
Sure. I will talk to anyone.
All right. I'm opening up for questions. Let me get you a mic, Jeannie.
I just wanted to ask that Dr. Ghoshal, is it typical if somebody were to get the FTD part of the phenotype of this disease, does it typically occur in the mid-50s? So if I'm 63, could maybe I think I skirted that phenotype?
Yep, fair question. So the way we usually think about this is if there's been anybody else in your family with that component of the phenotype and kind of what their age of onset was, and we can maybe map it to that. So we do this quite a bit in the inherited forms of Alzheimer's space. So we'll talk about kind of your family age of onset and are you plus minus that. That being said, there's a little bit of wobble in there. So I think everyone would love to be able to give you a clean bill of health in terms of the dementia piece, but we want to be careful about doing so. So I think so long as one has a mutation, the full spectrum of the clinical pieces you're allowed to have.
Okay. And while I just still have the microphone, during lunch, Gerald sat at our table, and I just wanted to say that probably in my late 40s is when I started tripping and falling, finding any crack, and I was having problems. I actually did go to the gym, and I wasn't able to do walking lunges any longer. I had to do stationary. So I knew I was walking slower, but it was when I went on vacation to Lake Tahoe in the summer and spent a lot of time in the hot tubs, like for happy hour, for an hour, hour and a half, that it was at that point, that's when my symptoms accelerated greatly. And I know when I mentioned this to Virginia, she was like, wow, I've never heard of that. But I'm just letting you know that for me, that greatly accelerated. Like I said, it was slower, but then I was no longer able to lift my leg on a chair. Instead of going to get the step ladder, I went to go step on a chair, and I couldn't put my leg up there any longer. And my balance was way off. And so I'm just saying raising my core body temperature really did affect my progression of the disease. So I'm just throwing that out there.
I have a question. Do you have any ideas or suggestions for patients on controlling pain? And then the other thing would be do you have any comments on supplements? Sometimes I've heard, taking, ubiquitin would be good, but then maybe we should be staying away from that kind of stuff. What are your thoughts?
I can start. So, I think pain is probably something that we underappreciate in this disease, and so I can't say that I have anything to offer unique for patients with VCP disease. I can say that understanding the burden of disease and understanding if patients do have pain and understanding that is really, really important. So that's the first thing I want to say. And so whenever you don't hear an immediate answer, it's because we don't really appreciate the amount of pain that patients might undergo with the disease. As far as, is there any specific treatment for pain? In any hereditary muscle disease, often patients need stretching. They get people that have different patterns of weakness start getting up out of chairs differently and put strain on different things. So whenever I think of the pain, I think a lot of orthopedic type pain. And so NSAIDs and things of that nature, sometimes escalating it with something like tramadol. There's also pain that's called neuropathic pain. And the neuropathic pain can be treated with things like Neurontin or Lyrica, but but there's not really anything other than those types of things. I don't know if Jerry has any thoughts.
Yeah, so I agree completely with you. And pain, of course, is, it's highly heterogeneous, highly individual. Some people find that, various lifestyle changes will improve pain. So I always try to emphasize those with patients. Activity, sleep hygiene, diet, things like that are also worth mentioning.
As far as supplements, I mean, we live in a Western world where really we get most of our dietary supplements in our diet. Having a bowl of cereal every morning is fortified. I don't advocate going on higher vitamins of any sort. I do, and when I see a patient initially, we do rule out that they have vitamin deficiencies that could mimic or be contributing. And so, most physicians will have done that, but I don't necessarily advocate going on extra, vitamins or any other supplements. Now, if somebody's on them and they think it works, I'm all for it. That sounds fantastic. And so I'm not saying don't do it. I'm saying I just don't know the answer. And so if somebody personally is on something and they feel like it's making a difference, as long, and they want to share it with other people, as long as it's not costing you, breaking the bank, then I think it's great. I actually don't know the data in dementia, and I'm going to defer to Dr. Ghoshal on that.
So I would say that supplements is a difficult area because I think, especially for us in dementia, we don't have a lot more to offer. We haven't had a lot of amazing drugs to offer. So I think it's a pretty vulnerable population who's looking for something. And then these all cost $60 out of pocket for this. Turmeric, I think somebody finally told me that was fairly cost prohibitive for them, and there's no good reason to think that turmeric at the doses that are taken, not regulated per capsule, per batch, get into any meaningful quantities into the brain. So yes, I was all for it. It's a supplement, it's a spice, and if you can afford it and it's not hurting you, but if it's starting to make for a financial hit. But I think there's a lot of, I'll stop short of saying snake oil maybe, but there's a lot of kind of, hey, what about Prevagen? What about this? What about that? We do know about vitamin E. We do know about vitamin B12. So as Dr. Weihl was alluding to, so we will check for levels for vitamin B12. That is low-hanging fruit. If that's the reason that you're having memory and thinking problems, we would kick ourselves down the line if we didn't check that and address it. But indeed, our Western diet, at least in North America, because they don't do it in the UK, we're B fortified. So the likelihood, if you are B12 low, we will see that in folks who are having other malnutrition issues, alcoholism, and things like that.
I guess I want to reiterate it. I don't want to say we don't know. So we do know, like Dr. Ghoshal said about vitamin E, B12. Like I know that taking more of that is not going to help you. There's data on that. I know that creatine is not going to be beneficial. But do I know that random whatever is beneficial? I don't know that. But it's not that we don't know. We know about some, and I can say it doesn't make a difference. But if you personally are taking it and you think it gives you, awesome, do it.
Yes, the only thing I would add, and this may have to do with where I practice, where we have long winters and little sunlight, is everybody's recommended to take vitamin D. Especially because, so we don't have specific evidence for VCP, but people with chronic neurological conditions tend to be indoors more, very common for them to be vitamin D deficient. Anyway, I'm not sure if there's a line in the United States where you would do the same thing, but in Canada we tell everybody to take it 1,000 or 2,000 units, something like that, and otherwise I have the same approach as my colleagues here.
Stateside, certainly, vitamin D for the MS population, I think is a pretty kind of standard of care there.
Can y'all speak about bone pain and treatments there?
Did you say, I'm sorry, Alice, bone pain?
Bone pain.
Yeah, so I ask every patient with VCP disease about bone pain in particular, and if they have bone pain, then I would advocate doing a bone density scan or getting plain films of the area that they're having pain, because I don't want to miss Paget's disease of the bone. So most patients, so you saw 40% of patients have Paget's disease of the bone. Paget's disease of the bone is actually very patchy. You can have it at some point and not have it at a different point. And so I don't want to miss that. I'll also check for alkaline phosphatase. That's an enzyme that you can check in the blood just to make sure that somebody doesn't have it, and because it's treatable. But that's the main takeaway that I do.
If I can add for pain, there is now a new initiative on pain research for rare diseases, and they are trying to identify the different molecular process, because pain is not just one pain, but there are so many different type of pain and type of receptors involved and signaling pathway difference. So maybe that would be something that the VCP patient participate to this new initiative about pain.
Sorry, what does bone pain feel like? Or what do patients tell you? How do you distinguish bone pain from the rest of the pain? Can anybody speak?
I actually do not know the answer to that. I don't know. We probably have patients out here that could help me and educate me on what bone pain feels like. That would be fantastic.
Peggy, do you want to tell what bone pain feels like?
Jeannie wants me to tell about my bone pain. I was diagnosed 21 years ago with Paget's disease before we knew it was related to VCP in our family. And my pain was just sharp pain in my pelvic area, my left pelvic area. And through the diagnostic testing, like you said, the bone's density and so forth, I was diagnosed with Paget's, and I was put on Fosamax for about a year. And I luckily have not had any problems, but we have had Paget's in our family, on our mother's side of the family, that has the VCP, for years. My grandmother had it too, but it was just sharp pain. And recently I just experienced in the back of my left hip area, upper leg, what I thought was bone pain. And I went to an orthopedic surgeon. My primary care referred me to an orthopedic, and he took x-rays and pictures and said, no, my Paget's looked fine, no bone interruption or no cracking or whatever, but he could see it in my pelvic area. And now I am going back to my neuromuscular neurologist to see if this is now the start of my muscle breakdown, because I haven't had any muscle breakdown to this point. I've just had the Paget's. So the pain is just sharp pain, like I'm getting in my muscle. I had it in my pelvic area with Paget's. So I don't know how else to describe it, just sharp pain. Thank you.
This is for Dr. Ghoshal. I think the FTD is kind of really the least understood, coming from me, patient perspective. We hear a lot in the news, or other people say early onset Alzheimer's disease. Can you explain the difference between early onset Alzheimer's disease and if that really is a thing, or if that is FTD, or if there's just a kind of mislabeling of what that is?
Fair enough. That's among the easier things I can probably answer today. So early onset merely speaks to symptoms before the age of 65, literally all it means. That doesn't mean that's how doctors are using it outside of the area of specialty. So sometimes they are meaning mild dementia, mild Alzheimer's, but really the classification of early versus late onset has to do with the 65 age split. That being said, early onset Alzheimer's disease, again, under the age of 65, doesn't tend to follow the textbook as much, can have more of a psychiatric appearance to it, can be quite a bit more overlapping with FTD. So FTD is another one of those diseases that often goes years misdiagnosed as being bipolar, schizophrenia, schizoaffective, all the different monikers until kind of the whole picture gets put together with some of the criteria I showed you today, and why we do look at the additional testing, why we do look at the imaging, like that all needs to hang together. I saw someone last week who has a 30-year history of bipolar, came to me because, hey, is this FTD? Like 30 years of symptoms, A, possible. B, then you would have a telltale sign on your MRI. There's no way this has been going on for 30 years and it's FTD without us seeing something on MRI. So it does get murkier. So early onset Alzheimer's is a separate entity than FTD. Depending on who you talk to, either FTD is the number 1 or number 2 dementia under the age of 65, the other one being early onset Alzheimer's. But it does have some overlapping features and takes a little bit to kind of tease out.
So I have a question, maybe for everybody, but for Dr. Weihl. For Paget's disease, I was diagnosed with mild Paget's. My neurologist, I went through the bone scan and I have mild Paget's, but there's not a whole lot of pain with it. But is it worth treating? Because my doctor said, no, you don't need treating. I'm not gonna do that. But is there a reason not to be treated?
Yeah, so I never want to second guess another physician because I don't know the full circumstances, but if you were to ask me, there's no downside to treatment for Paget's disease as far as taking a bisphosphonate. It's actually one injection. There doesn't seem to be a downside. Can you have mild Paget's disease? I'm not even certain I know what that actually means, but you can. Paget's disease should be treated. It can actually turn into cancer. It can actually, there's reasons to treat it. So I would kind of push back and just ask. And if your neurologist isn't comfortable with it, so I would not treat Paget's disease. I'm a neurologist. I would send you to an endocrinologist. I think that's one thing to think about. Like, we often get mad at doctors because they didn't do it, but let's actually reach out to Nathan and say, should my doctor be prescribing this? And he'll reach out to me or something, and I'll say, no, the endocrinologist to do it. So I think that's how I would approach that. So.
Okay, and thank you for that, because I'm going to do all of that. But I have a second question related to FTD, and mental health, and I think we're going to talk about more about this tomorrow, but anxieties that I know I have, I'm not going to speak for everybody, I think more than we have a lot of this. Could our anxieties that we have with our issues that impact our mental health, could they cause symptoms that could be perceived as FTD?
Absolutely. So we hear about a myriad, I didn't, kind of line item all the different behaviors, kind of the ones that kind of popped to mind mostly, but I was speaking with others in the group today and during the breaks about agitation, irritability. All are fair, and all are fair responses to what you're dealing with, right? So what is a pathological other symptom due to FTD, and what is because you've got a lot on your plate and you're sorting through a lot? And then there's a family component to it, and siblings who have it, parents who, so forth. So I think some of it I think it could get interpreted one of both ways. There are good medications for that as well. So not that we are med pushers, but let's be honest, if there's a symptom and we have a good way of addressing it, we should do. What was that? Well, yes, can do, yeah. we can, yes.
I have a question directed mostly to FTD, but understanding Dr. Pfeffer said that he was thinking underreported numbers, and I just was thinking, or overreported numbers in some areas. I was thinking underreported. When you diagnose someone with FTD, you don't go ahead and do a VCP kind of test on them, and they could just get FTD without any of the other components. How do they go about determining that? And I know we have some people here who just have FTD, so there must be a formula for that, but I don't know what it is. I'm just kind of curious.
Yeah, as Dr. Pfeffer was talking about, we are taught to think most about the common things being common, so the acquired non-hereditary forms. So I think that is a true reflection of the percentages of cases out there. So I think that generally serves our patients well. That being said, in FTD, we certainly know that if we ask the right questions, and I'll give you examples of what those are, that 20 to 40% of the time we'll hear about a family history. But if you hear about what everybody in this room has, that doesn't just mean FTD. That does mean asking about muscle issues broadly, right? Like, doesn't have to be the name of it, but they had some muscle cramping thing. They had some neuropathy type of thing. They had some weakness type of thing. And if we ask kind of those broader questions that encompass things like ALS, Parkinson's, and so forth, you can often develop quite a family tree like Dr. Pfeffer showed, and then you go, oh, a couple different generations, something happened in each generation, and now I want to go ferret that out more, and at which point the genetic counseling would come first. I didn't mention that in the All-FTD program, that's actually clinical services that we provide that are supported, paid for. So you would get genetic counseling, and I encourage everybody to do that when they're in the study, and regardless, that you can go right up until the brink and go, yeah, I'm good, I don't want to get tested. So it's not that once you go down that path that you can't get all the knowledge and still say, I want to get my long-term care insurance. Let me just hold on a second, right? So you can do all that, and that's supported in the study. But get your knowledge. Make sure you understand what you're getting yourself into. But I would say there are clues in the history if we ask broadly enough, which we do. We had somebody recently I see for thought to be garden variety FTD, and then we found out an uncle turned out to have something a little bit maybe similar, as we kind of found out through family reunions and so forth. And that flipped everybody's script. So the physician seeing the uncle in the Barrow system in Phoenix wants to do genetic testing. We're going to do genetic testing, but it was that tipping point of hearing about another generation of involvement.
Thank you.
I would like, if nobody has question more about FTD, I would like to address the question about fatigue. That's a big part of the patient have. And I would like you to maybe have some comments. Do you think it's the mitochondria part of the disease? Is it the depletion of ATP because of the variant that produce all the energy, uses all the ATP? I don't know. What do you think about the fatigue that's part of the disease?
Yeah, so Dr. Pindon's bringing up another symptom that is really hard to characterize. And so we named one pain. Pain is really hard to characterize. You can have pain for lots of different reasons. And so you can have fatigue for lots of different reasons. And so I think the most important thing that I tell my patients who have fatigue is that you're a normal human being, and we better make sure you don't have anemia or something like that. So please go see your primary care doctor and make sure you don't have hypothyroidism. Make sure you don't have other causes of fatigue. And so it's hard for me to answer that question directly because I can't say that the patient that comes and says they have fatigue has been evaluated for all these other things. So does having a hereditary muscle disease, does that lead to fatigue? Well, I will say that you're probably working harder to move around than anyone else is. So, that can lead to fatigue. But I'm not sure that I know the answer to, is there something biochemically going on? One thing that we don't do well in clinic, and we can actually ask Megan about it, we don't measure fatigue in clinic. I don't do a test. So I might do a test at how quickly you can get up out of a chair. I might do a test to see how far you can walk 6 minutes, but I don't measure fatigue. And so that's something that's an outcome measure that probably is really relevant to patients that we just don't measure. And so I don't know until we really start thinking about those things. And again, this is where patient-focused research is helpful, is kind of the idea. So I'm giving you a very vague answer because I just don't know the answer.
Yeah, I would give an exceptionally vague answer as well. It is something that gets discussed, in clinic. It's a very common symptom, of course. It's common among people with neuromuscular disease. It's common among people sitting in this panel. I can tell you that at least one person here feels fatigued for some reason, maybe more than just me. But yeah, so what I do find with my patients is that so it comes up frequently. Often it seems like lifestyle modification can help with that. So I guess that's like the 10th time I've said lifestyle today. But often people will find things that work for them if they tinker with their lifestyle. Now, which things? If I thought about 10 different patients, I could give you 10 different answers. It seems to be very individual. And then, of course, for 10 people who find things that work, there are 10 that don't find anything that really helps them. And yeah, but otherwise, in terms of mechanisms and so on, I have no idea. It would be a very difficult thing to study. Yeah.
I'd say just to piggyback on what Dr. Weihl was saying, that common things are common. So certainly in dementia clinic, I do a good screen for obstructive sleep apnea. I mean, you are allowed to have the things not related to VCP. So let's listen for those things. Let's make sure we're assessing them. I sometimes have to go out on a limb to explain why I'm asking about sleep in memory clinic, and it's when you're forming good memories and so forth. And I've had, a handful of patients who come back to me. It's like, oh my God, CPAP. Like, where was this my entire life? And now I have such good quality of sleep, and my quality of life is so much better. So you're allowed to have the other things as well. So we should not be so focused on, is this VCP-related fatigue, but rather the other causes. So, Dr. Weihl talked about anemia, hypothyroidism. I'd add sleep apnea to that.
And I would agree with all of that. And so I think it's good to be checked. And I have been checked for, sleep study things and other causes. But I also want to point out, to one of your questions was that I think pain really wears a person down. That and then emotional stress really wears a person down. So getting 12 hours of sleep at night, waking up, feeling great, but then needing a good afternoon nap, and for me, a nap could be 3 hours, and then I feel great, and then I'm ready for bed. So that could be a day for me. That's a lot of sleep, so just a comment.
I had a quick question about, in speaking with a lot of the other patients at these conferences, everybody seems to have a different path, whether it's a different way the disease presents itself or how long it takes as they degrade over the time. I know as we go forward and do a lot of these research studies, that's going to give us more data. But, as you talk with people, like Jeannie just mentioned that, she thought the hot tubs and the other things gave it to her. I know that I've heard falls and other things. What are some of the things that trigger this? Because I feel like over the last couple of years, I was going for a certain period of time, going very slowly, and all of a sudden it just dropped off. And I feel like over the last 2 years, I've gone downhill very quick. I'm wondering, what could it be? I mean, I know I've had a couple falls and I haven't been able to exercise as much, but what are the things that typically accelerate this? Is it the age? Is it, what are some of the things that you identify as doing that?
I think that's a phenomenal question, and I don't know if I can give you an answer that I know is going to be unsatisfying to a lot of you, but I can also give some other informed things. So one is an injury of some sort, a fall of some sort, really sets people back. And so is that the pain that then limits you from doing what you want to do? That's one thing for sure that limits people. We know patients with not just VCP disease, but with chronic muscle diseases, if they injure themselves, they have a harder time rehabbing and getting back. And so that's one thing. The other is a major illness, and so we've just gone through, or still are within, a pandemic, and so patients having the flu or COVID or something like that can really set someone back. And so there are illnesses that can set somebody back. I mention that because that is something that we talk about all the time as being potentially modifiable with vaccines and things of that nature. The unsatisfying answer I'm going to give you is that in theory, and I'm just telling you how it should work in a mouse model, how it should theoretically work, is that your trajectory should go like this as far as muscle breakdown. And patients tell me all the time, no, it was going like this, and then all of a sudden I got worse. And my question is always back at the patient, do you think that maybe all of a sudden you couldn't walk up that step, which means that you maybe met some threshold of weakness that appears and makes it feels like this stair step. But actually, if we overlay this stair step, your disease pathogenesis or the strength, weakness has gone in a very slow kind of progression. But every once in a while, you're like, I can't get up out of that chair anymore. And you think, oh my gosh, I'm tons worse. And so I don't know. That's what I try to reflect back to patients. And some patients are like, yeah, I think that might be right. And some patients say, no way, I got worse on Friday. And I'm not going to argue with you. Maybe that did happen. I don't know. And so I just don't know fully the answer. And I think that's where, and we talked about this at lunch, that's where prospective studies rather than retrospective studies. And so in a retrospective study, I'm trusting your recall. I'm trusting that the doctor who did the exam back then, whereas a prospective study, like a natural history study, I might be able to really answer your question because I'll be able to monitor everybody in the exact same way and be able to tell you and be able to say, nope, you're, over the last 6 months, you've gone just like this. But there may be patients I'm totally wrong, and there may be patients that go totally like this and then all of a sudden go like that. And so that's where the natural history studies can really kind of inform us, not just from a, can we find out the right outcome measure for a clinical study, but also to inform patients about what's going on. So
I'll add to that from the dementia space that we certainly hear everyone wants to know how much more time do I have and so forth. We do a little bit of that hand waving while everyone has their own trajectory, barring other illnesses, as Dr. Weihl was talking about. So their data and our PT folks in the audience can help kind of support that, where I know there's a frailty graph that I seem recalling that I presented in my biology of aging class, where it is your ability to kind of rebound from a fall, a fracture. So long as I have someone who's very healthy and not on a bunch of meds and having other health issues, they can I can expect them from a dementia vantage point to continue on that slow burn trajectory for a long time. They have a fall, they have a hip fracture, they go to rehab, they don't quite gain their independence back, they don't quite ever get back home the way they were, and then it seems like the more precipitous decline comes thereafter. And then, yes, all the folks we've been seeing during COVID who've had a year's worth of symptoms, I'm like, could it be COVID? Could be. We'll have to see how they do as we come out of this. But yes, we certainly hear about the other health issues, and we certainly know, we often talk about everyone having their own trajectory as a sequence of yet to be defined things that seem to be that tipping point for them.
Okay. I'd like to jump back real quick to the fatigue question. There was just a follow-up that I had while you were talking. So I understand that it's not something you typically test for in clinic. Just because I'm the type of person that likes to pay attention to what's going on, and if I was to bring an idea to my neurologist, what's useful information? What types of things might tell you that there's something related to fatigue? Should I track sleep hours? Should I look at recovery time from exertion? Is there something that I can take as data? I know it's not clinical. I know it's not significant, but it might tell you there's something there, something to work at, something to look for. If it's something easy for me to track and I can show up with, a printout of a spreadsheet for the last year or 6 months to show my neurologist, is there anything useful that I can do on my own?
Right.
Over.
So I want to first reflect back that I believe you that you're fatigued. So you don't need to prove it to me. If you say you feel fatigued, I believe you. I'm just saying I don't know how to test for it very well. And so you're asking a great question. I'm actually going to hand the microphone to Megan because she may have ideas of how we measure fatigue in clinic. And if I'm putting you on the spot, let me know.
Yeah, so I think specifically it's important for you. So tracking what makes you fatigued is an important thing, maybe not necessarily for your neurologist, but for you, for how to plan your life and how, if you know you're going into these activities and you want to do these things that you have documented in the past, that these make you really exhausted, you sleep for much longer afterwards, then talking to your physical therapist, talking to anybody that can provide you ways to support you to do those activities so that they're not so fatiguing for you. As far as like quantifying fatigue in the clinic, I think we look at, it's really, there's so many factors that go into fatigue that it's very difficult to kind of parse out what is what. And I think muscle fatigue is different than general fatigue. And so there are some patient-reported outcome measures that look at and ask about fatigue, but again, there's so many components to it that that's kind of a difficult thing. But from a personal level, I think it's an important thing to track and keep a diary of to help you.
I can comment a little bit on that. We had a really interesting phenomena happen. I mentioned that we did a video study for a condition called PMM, and it's primary mitochondrial myopathy. And so one of the characteristics is this fatigue factor that we didn't really know how to measure. So we captured videos kind of traditionally like we've shown. And we had this really serendipitous moment. We had a couple of patients who had videos that either glitched while they were capturing them. We had one person walking up the stairs, and in the video, her dog ran in front of the video, and so they kind of laughed about it. So she repeated the stairs. The dog ran in front of the video again, and so she had to repeat the stairs a third time. And so at first we were thinking, oh, we have to throw this out and recapture. But I went through our scorecards, and you could see decline over all 3 attempts. So that's something that we're looking at in PMM is not just, this one-time video capture, but can we quantify this decline over repeated measures, if that makes sense. So that's something we could even consider for VCP. And you could see her scores the first time she attempted it were, higher, and then they progressively declined as she climbed 5 stairs. So something kind of interesting to note.
Yeah, I think related to that, as a patient, I've made comments to Megan and others that we should be doing these things. We should see the difference. We do it first thing in the morning, and then like all the nationwide stuff, and then let's do it again the same day at night. Because I know at the end of the day, there's a massive difference between my level of energy from in the morning. Maybe it's after my coffee, might have something to do with it, but in the evening it's different. But I want to talk specifically about a comment that was made, about our decline, and suddenly, we'll plateau for a little bit and then we'll decrease. It's happened to me where maybe I don't know why I've seen this sudden decline, but in most cases, I know exactly why. It's me. And I'm often my own worst enemy. Specifically, a couple months ago, I was working in the yard. Melissa and I were working in the yard, fixing irrigation system. We were coming into spring and needed to turn on the irrigation system and had to do a lot of fixes. Me being pig-headed, as soon as I realized that I should have hired somebody else to do this, I said, no, I'm going to do it myself. I'm going to finish this. I should have just stopped and hired TaskRabbit to do it, but I was my own worst enemy. And I noticed a significant decline in a period of a day because I pushed myself. And that's function I will not get back. I don't think I'm the only one, but I know that. And we all probably do things like that. We all push ourselves, but, it's just me. So sometimes, and you just got to think about it and look, what did I do to hurt myself?
I take that in a little bit different direction. So self-awareness, and don't beat yourself up too much. We're a good amount of pig-headedness got us where we are to be able to succeed. But I would say that I do worry about that in some of our studies as well, and just even in our patient population outside of studies, cognitive testing, right? So are you a morning person? Are you an afternoon person? When did we test you? Did we give you your best shot? So ways that we've been thinking through that, been some remote capabilities. So Brandon and I've talked about TabCat and some phone-based apps and things like this. Several benefits. One is testing in a sterile room where there's nothing to distract you is probably not you on a good day, functioning in the real world. So something beeping at you when you're in the checkout lane might be a little bit more real about your ability to multitask and stuff like things like that. Also, similar to the neurofilament study, multiple data points. Even if you ignore the beep, you're probably still going to give us a data point once a week, which is something we weren't getting but once a year. So trying to give you your best shot at performing in a real world scenario that says something about your functionality in the real world. But also, why I was raised in the era of biomarkers, so I know the cognitive neurologists fawn over the paper and pencil testing, and these are the reasons I have concerns about them. I have a patient of mine who drove 14 hours overnight from Vegas to make sure they got to my clinic appointment. Probably didn't do so high on their paper and pencil testing, but his brain volumes are probably what they are on an MRI, his spinal fluid, his blood tests, and things like that. So I think that's where some of these other surrogate biomarkers provide other averaging kind of measures that don't ask you to be the one who has to perform your best, and it's not performance dependent on whether you've had a good day, good sleep, good whatever.
So I don't know if there's a clear answer to this question, but I just wanted to ask the ratio between normal VCP and defective VCP, is there a way of measuring that? And I know that the onset of disease occur when you take it all completely away, but over time, do you happen to have more normal VCP when you're younger? And at some point in time, do the more defective VCPs kind of take over, or is there more of it? And how can you measure that?
Yeah, so that's a great question. So so you have it in theory, and I'm just going to tell you theoretically, it should be 50-50. 50% of your VCP would be the diseased VCP, and 50% would be the wild type or the normal VCP. And you've had that your whole life. And so you're right that how do aged diseases happen? And so one possibility is that you're slowly accumulating that trash, and all of a sudden you accumulate too much, and your muscle fibers or your brain cells degenerate. That's possible, but what's probably actually happening is that you're able to compensate for that. And for some reason, as we get older, just anybody that gets older, we start to lose the ability for our cells to compensate for having accumulation of trash. And so to go back to the analogy, as we get older, the trash man only comes once a week instead of twice a week. And so as we get older, these compensatory things seem to happen. And so aging is clearly a component of this disease. And so I don't think that the VCP perhaps, or that VCP levels or VCP activity changes as we get older. I think what happens is the other people that are trying to help out, or the other proteins that are trying to help out, can't keep up as well. And so, and I say that with some knowledge in that if we were to biopsy somebody prior to the onset of weakness, their muscle looks relatively normal. It's not accumulating trash. It's only once they've developed weakness or developed disease that we actually see the accumulation of this kind of trash. And the same is true whenever we think about, Dr. Ghoshal was talking about neurofilament. And so people have normal neurofilament levels, and then all of a sudden it goes up. And so clearly something has happened, and whether that is an aged effect or not. And so, we talked about therapeutics specifically for VCP, but one therapeutic that can be done that people are thinking about is, can we make an aged body feel like it's younger, or recognize that it's younger? So could I delay aging, but not delay aging? Could I trick the cell into thinking that it was 40 instead of 60? And could that stave off the onset of disease in some way? So there's lots of studies looking at longevity. And so that's another therapeutic option that could be done for many aged onset disorders.
So I know that there was a patient that said she was doing some heavy lifting. You know, she realized she was getting weaker, and so she was one of these, you know, bodybuilders. So if we have this disease, did it make it worse? Or what Todd was saying is maybe over fatiguing the muscles that you don't get it back. But on the flip side of that, right before COVID, I went up to see Jim Weimer at UF because he was one of the Amalex study sites, and he had that Atlas chair. I wanted to do a baseline of what my muscles, you know, were doing. And when Peggy and I got there, the study coordinator said that she had to do a software update. So I didn't get it before the COVID. And then 7 months of not exercising because there was no way I could wear a mask at PT because just walking is exerting. And then when you were doing PT, I couldn't breathe with the mask on. So when I went up there and I finally got my baseline, it was 7 months of not exercising. I know I was only able to exert 21 pounds of pressure on my left quad, and that I know was my strongest quad. After that, I had my OT assistant come to my house 2 to 3 times a week, and I did that from July to March. When I got measured again on the Atlas chair, I went up to 51 pounds of exertion. So I'm not a statistician, but I'm thinking that's about 150% increase from 21 to 51. So I'm now doing an exercise where it's robotics. It's 20 minutes twice a week. It's called the exercise coach. But literally the machine is giving me pressure and I'm pushing against it. And I could see every time, am I improving? When I went on Wednesday, I gained 50% more than the last time I had been there in just that. So is there a point where you shouldn't overstrain your muscles? Is there a point where you do damage? Or is it where you can go ahead and work out and build muscle so that hopefully, you know, my quads are stronger, my hamstrings are stronger, that I could walk better and stuff like that?
So, Jeannie, what do you think I'm going to say? I don't know the answer. But I applaud you. That sounds phenomenal, and I'm totally excited that you're able to do that. I would say exercise is good. Exercise is good for patients, but I say that knowing that some patients can't exercise, and so I feel bad saying that. So I don't want anyone to feel bad, and so I would say if during COVID you couldn't exercise, that's okay. I mean, that's you know, some people can't exercise because they have pain. Some people can't exercise because they can't get onto the equipment. So. But exercise is good. Figuring out ways to exercise are good. I think one of the hardest things, and hopefully you guys will talk about this more tomorrow, is how do you exercise whenever you have an evolving body that's changing in its limitations? And so I know whenever I say to a patient, hey, why don't you exercise? I think immediately they think, I guess I need to go run 5 miles. That's not what I said. That might be how you think exercise is, but how do you reframe that? I also say people, you should go to the pool, and someone will look at me and be like, I hate swimming. I'm not going to the pool. So me being prescriptive, which is what you're asking, Jeannie, is what prescriptive measure, how much exercise should I do? I don't want to do that because everybody is different. Everybody is personal. And I really think they need to do what works for them. And I think that's awesome. And I think sharing that with other people and encouraging them is excellent. And so I think that's how I would answer that question, but I just don't know the answer. The other caveat I would say is contrary to maybe what some neurologists say, you can gain back strength with this disease. There's nothing saying that can't happen. Now, if you're really weak in your arm, is it really worth trying to get all that energy and focus on that, or is that going to be frustrating? And so focusing on other aspects of muscle, whole body workouts are probably better, but But I'm not going to say that if someone tells me that they've worked out a certain muscle and it's gotten stronger, like I think that's great. I just don't have a prescriptive measure for it.
I would agree with that. For our dementia folks, I'll say, you have my various quips, but you're not allowed to become one with your Barcalounger. That's like my bare minimum. Now, that doesn't mean I have colleagues in our partners who will say things like 30 minutes 3 times a week, and I agree with Chris that just doesn't fly for everybody. But do the little bit more than you have been. So if that means going down to your mailbox at the end of your lane, and that's as much as you can do, but it's more than you've been doing, great. Then that's your goal. If you have arthritis and swimming does work for you because it's weightless and not weight bearing, great. So I think encouraging people to do it. The other part I would add is that we do know there's data now, like we've always talked about heart healthy as being brain healthy, kind of these hand waving things. There's actually great data for it now that even when people were self-reporting physical activity, self-reporting cognitive activity, so meaning you kind of said what you were doing. We weren't telling you what to do. That the brain shrinkage that we do see in that was it was done in FTD, not with VCP in mind, it can kind of mitigate the inevitable change. So test scores continue to do well even though brain was shrinking because of keeping your mind active, keeping your physical self active. So I think that's just kind of gave us more teeth to what we've always been saying, but good data for that now.
All right, and we.
Can I just add something to what she's saying? I'm a cognitive therapist. I work with clients that have different forms of dementia. And doing what you're saying, I have seen tremendous changes in my clients in their abilities to think a little better, function better, interact with other people with the cognitive exercises along with the physical exercises. So I've got to
Yeah. Okay.
thank you very much.
All right. We have time for one more question. And then,
So I just want to piggyback off of what Todd was talking about working in his yard, and then Tom's question about the rapid decline. I talk a lot about in happy hours and stuff about ambiguous grief, and that's grieving a living person. Well, the living person that we're grieving is us, essentially. And I'm not a doctor, but I'm a patient with high anxiety and PTSD and a lot of grief because of this. And I don't want patients to forget that a rapid decline could be because of a mental health issue. It could be because they're really struggling with familial, watching their family. They could be really struggling inside with how this has happened with their diagnosis, those things. So please don't forget your mental health because it does affect our physical health, and it's so, so important.
I think that's great advice, and thank you so much for sharing it. I'm going to tell you, just from a doctor's perspective, patients come, they might have a neuromuscular issue, and I ask everybody, how's your mood? Do you think you're depressed? And I don't ask that to point out a weakness in anybody. That's not what I'm doing. I'm not doing that to say you can't handle it. I'm doing that because, as Dr. Ghoshal said, I have some medicines for it, and we can treat anxiety and depression. I'm not saying it's easy to treat, but I'm just saying it's a conversation, and my job as a doctor is to treat the whole patient. And so I guess I would just encourage you to recognize that doctors are doing a bid and not saying you're crazy, not saying you can't handle it, not saying I don't want to deal with you tell me you're fatigued. I just told you honestly, I don't know how to treat fatigue. But I know how to treat depression because there's medications. So you might say you're fatigued, and I might say, well, are you maybe a little bit depressed? And it's not because I'm diminishing your fatigue. It's because that is something I can do. So thank you, Amy, for bringing that up. But I just wanted you to hear it, how we as doctors think about it, that it takes a receptive patient as well.
I think it's good as a doctor that you share your side as well. It makes us better patients for you. So thanks.
all right. Well, thank you to our experts, our VCP experts, for taking the time to be here today.